To start our evening. Hello, everyone. Thank you for joining us. This is our fifth and final series in our spring CME event for the Department of Urology here at Yale. I'm Therese Gardier. I'm a pediatric nurse practitioner in the Department of Urology at Yale. I'm also the CME director. Tonight, we are going to hear from Dr. Leslie Rickey and Denise Tortora about incontinence, specifically in females. This will be one CME. You will get a link tomorrow for viewing this after the event, and CME will be mailed out from the Department of Urology at Yale. We are going to have both speakers speak and then a Q&A combined at the end. Please feel free throughout these lectures to use the chat to type in any questions you will have, and we can certainly unmute people's mics at the end to ask questions as well. So our first lecture tonight will be from Dr. Leslie Rickey. She is an associate professor in the Department of Urology and Obstetrics, Gynecology, and Reproductive Services at the Yale University School of Medicine. Dr. Rickey earned her medical degree from Tulane University School of Medicine and has an MPH from Tulane School of Public Health in epidemiology. She completed her residency in urology and fellowship in female pelvic medicine and reconstructive surgery at Loyola University Medical Center, receiving subspecialty certification in 2013. Dr. Rickey was on the urology faculty at the University of Maryland School of Medicine from 2007 to 2013 before accepting her current position at Yale, where she is also the female reconstructive surgical urogynecology fellowship director. Her clinical practice focuses on the treatment of female pelvic floor disorders, primarily urinary incontinence, overactive bladder, and pelvic organ prolapse. She is currently the principal investigator on the NIH grant as part of a multi-center consortium studying prevention of urinary tract symptoms in women. Our second speaker tonight is Denise Tortora. She's a physical therapist who graduated from the University of Hartford with her master's in physical therapy. Shortly after graduating, she moved to Boston and worked for Harvard Teaching Hospital, Cambridge Health Alliance. She was then accepted into the residency program through Leahy Clinic in Burlington, Massachusetts for pelvic floor physical therapy. Following her residency, she opened her own private practice in Cambridge, Massachusetts. She then moved back to Connecticut, where she has worked on starting a pelvic floor physical therapy program at Yale New Haven Hospital. In 2016, Denise received her WCS board certification through the American Physical Therapy Association. Denise was published in the 2019 Connecticut Journal of Medicine for the prevalence of urinary incontinence in collegiate female athletes. She has been at YNHH for 6 years, establishing and managing our pelvic floor physical therapy program. I want to thank both of you for joining us tonight and apologize for the dogs in the background. They're up for grabs. If anybody wants them, put that in the chat too. Dr. Rickey, it's all yours. Thank you.
Sure, thank you. Make sure I get this up. All right. All right, so I want to thank everybody for being here. And I'm going to be talking about urinary incontinence in women. My, as Therese said, and thank you for that introduction, my research and my clinical practice focuses on women. And I'm going to spend a few minutes at the beginning, in urology and in urogynecology, people present to us with symptoms already, but there are a lot of women out in the community that either have mild symptoms or can actually have severe symptoms that are suffering with them, but don't present for care for a number of reasons. There are both patient and provider barriers. So I'm going to spend a little bit of time at the beginning talking about that. These are my disclosures. So LUTS, which is shorthand for lower urinary tract symptoms, the impact is quite impressive when you think of all LUTs together. And this is inclusive of incontinence, overactive bladder, recurrent urinary tract infections. And it's actually being increasingly recognized as a public health issue. So the economic costs are enormous, like overactive bladder alone, and this is old, this is over 10 years old, was estimated at $66 billion. Recurrent UTIs are a big drain on healthcare resources and cost the healthcare system about $2 billion annually. LUTs is associated, like incontinence and overactive bladder, with decreased work productivity independent of other factors. In terms of, lost days at work and lost productivity while women that are at work. In terms of morbidity and health, depression, weight gain, obesity, decreased physical activity, and diabetes have all been linked to LUTs. And LUTs also independently predicts increased emergency room visits, even when controlling for comorbidities, age, and race. So there's this concept of the hidden burden of LUTs impacting wellness independently, as well as possibly making some of these comorbidities worse and worse, like it's harder to treat them. For instance, for somebody that has diabetes, they might be told to eat better and drink more water and go out and exercise. Well, if someone's leaking every time they exercise, or the increased water makes them have more urgency incontinence, they're less likely to uptake some of those healthy behaviors. So it's sort of a catch-22. And as those other medical conditions get worse, they can then make incontinence worse. So there is definitely some benefit to treating lower urinary tract symptoms that goes beyond just the immediate symptom impact. So just one example of women with overactive bladder, you can see here, 40% report interference with daily activities, 38% report decreased physical activity due to overactive bladder, 12% stay at home more than they want. For all of these reasons, they're also more likely to report disturbed sleep. And all of these things result in a lower self-esteem, feeling of declining health, and worse mental and physical health status. So I think we need to reframe LUTs a little bit, both in the urology world and in the primary care world, that it's not just a quality of life condition, it's actually an important chronic medical condition that either directly or by kind of indirectly, by moderating activity, depression, work productivity, mental health, leads to worsening of some of these other more highly prioritized medical conditions like obesity, diabetes, cardiovascular, musculoskeletal issues, depression, and on. So, and these arrows are probably not completely accurate. I think they're more bi-directional. So I think, again, this is why it's being increasingly recognized as a public health issue. And this is why the NIH decided to fund the work type of work that I do, looking at trying to prevent lower urinary tract symptoms earlier down the line. I mean, it's really, people don't wake up at 40 leaking and like something happened the night before, right? Like just like all chronic medical conditions, there's probably an accumulation of behaviors, risk factors, things that we haven't really studied yet that probably start in childhood, just like other chronic medical conditions. So this isn't specific just to urology, but in primary care in general and in chronic medical conditions, there's this iceberg. So at the top of the iceberg, these are the people that have been presented and are diagnosed. These are the people that are showing up in our tertiary referral clinics. But there are many, many more people below the surface that either have the symptoms, but they don't really recognize that it's a thing to be concerned about. They may recognize the symptoms, but they haven't presented for care yet. And then there's also people that have presented, but they're not diagnosed. Either the questions aren't being asked at the primary care level, or people really don't want to bring it up. So this is the challenge. So the other thing that's interesting about urology is the appreciation for urologic issues in the community is relatively new over the past 10 years. 10 or 15 years is when the first community-based studies were doing. So again, not just the people that are in our office that are the most affected, that have the wherewithal to ask the questions and get into our clinic, but the people living out in the community. So 20% of women that are 30 years and older have moderate to severe lower urinary tract symptoms. And of all community dwelling women, about 3/4 report at least one urinary symptom. So I think these people that are in the red box are probably where we can do a little better chance of identifying at the primary care level. There's barriers to presenting for treatment and then getting the treatment. And one study found that when they sent surveys to all women in like an integrated care system, like a Geisinger or a Kaiser type place, they sent surveys to all the women that had no diagnosis, no ICD-9 or ICD-10 code in the system. And they sent them all like a survey asking about incontinence. They found about 40% of the women actually had like moderate to severe urinary incontinence. Only 5% of the women had documentation of symptoms in the EMR. So there's something happening in the provider to patient communication where these moderate to severe symptoms may or may not be bothersome, but the conversation isn't even happening. And we know a lot of times women are not going to bring it up. So again, this isn't all on the patient or all on the physician, but I think there's a combination of things going on. So the most common things that women state in surveys for not seeking care, unfortunately in our society, female LUTs are normalized, you know, through like all the pad ads, and you know, you see these long lines of women waiting for bathrooms and no one seems to care. There's a long line for women, but no line for men. So there's this normalization of female LUTs in our society. So a lot of women just think it's something I had to live with. Some don't want to take medication. Some say, well, you know what, I'm dealing with it by wearing pads. So it doesn't interfere. I control it. That gives me the confidence to do what I want to do. I was uncomfortable or embarrassed. I didn't feel it was enough of a problem. The healthcare provider didn't ask me about my urinary health, and I wasn't aware anything could be done about it. On the primary care side, these are the reasons that primary care physicians cite. They're unfamiliar with any kind of accepted algorithm for treatment. They don't have a good screening tool, and they're uncomfortable with diagnosis and treatment. And you know, I think to some extent there is also a time burden for sure. Primary care physicians are dealing with so much, but there's also this like, you know, I don't really know what to say to people, so I don't want to bring it up. One of the things that worries me a little bit about people that think it's not severe or frequent enough to treat, and I don't want to suggest that everybody that leaks once every 3 months needs to run into an office, but we know that symptoms progress. Like they progress as women age. And in fact, 20% of women with monthly stress incontinence symptoms will progress to weekly by 5 years, and 25% of women with weekly will progress to daily. So it's sort of like we just don't know who's going to progress and who's not. Not everybody progresses, and not everybody gets to a really significant, impactful place. But there are some people that do. And again, that's something else that we're looking at in our prevention studies. So, you know, again, this isn't a mystery. We know this. You know, when you look at urinary incontinence prevalence in each decade, it increases. You can see that top blue line that kind of goes up and then down. That's stress incontinence. So that tends to peak more in the 40s and 50s. And it's not that it like disappears or goes away. It's just that the type of incontinence, urgency incontinence, then takes over. And for those of us that see women with incontinence, a not uncommon story is like, oh yeah, I leak when I cough. That happens here and there, but now my urge incontinence is getting worse, and that's why I'm here. Like I'm having these uncontrollable accidents. So overall, with each decade of life, incontinence prevalence increases. So yeah, you know, even if someone's having sort of infrequent, it's still a good idea, I think, to maybe ask about, address, and maybe start instituting some earlier interventions or behavioral changes that might be helpful. So for stress incontinence treatment, just to start with, and Denise is going to go more into pelvic floor muscle training, therapy, exercises, what the role of physical therapy is, but also some first-line treatments. Weight reduction has been shown to decrease incontinence episodes in obese women. This same evidence is shown in the bariatric literature for women that undergo surgery for weight reduction. Pelvic floor muscle exercises, this can be done. Some women are okay doing them at home. And after 3 months, there's a significant improvement in symptoms. This has been shown. There's level 1 randomized controlled trials that have shown the benefit of pelvic floor muscle exercises. Again, some women can do sort of the primary treatment on their own. Some do better with the pelvic floor physical therapist, and some people just have some more complex musculoskeletal issues going on that benefit from pelvic floor physical therapy. But I'm going to let Denise go into more depth about that when she talks. We also use incontinence rings. Now, I'm not expecting primary care providers to have these in their office. This is more just to let you know some of the things that we might use in our office that are non-surgical. So, and in women with mixed incontinence or stress incontinence that were given a choice, about 2/3 chose a pessary trial. Of those women, about 90% had a successful fitting, and about 50% of them were still using them at 6 months. So this can be a nice non-surgical option for some women, and we teach them to take the rings in and out on their own so that they can manage them. Side effects or complications like erosions or infections are pretty uncommon. Moving into procedures, we have a sometimes office-based, sometimes outpatient procedure called periurethral bulking, where we use a cystoscope to go into the urethra and inject a bulky. I tell women it's sort of like fillers, because people seem to be familiar with the concept of fillers for facial type things. So we're going to inject a bulking agent at the bladder neck. So you can see here on the right, you do it on both sides, and that works by coapting the bladder neck, increasing the resistance outside the bladder. I like to tell my patients that the main treatment for stress incontinence is all aimed at increasing the resistance outside the bladder. So it's less really a bladder problem and more of a bladder outlet issue. So you can see here, they had about 30 to 40% of women dry, about 50% improved at 1 year. There are a fair number of patients that require a second injection to get dry. There's not a lot of long-term data for this procedure. The conventional wisdom is that it sort of wears off over time. And so they do tend to need injections every couple of years. But for someone that like can't take time off of work, really can't deal with the activity restrictions, need something done quickly, it's a pretty good procedure. It's not my favorite thing to do over and over and over again in young women, but I think for someone that is a little bit older, it's a good procedure to get them some little bit lower risk, lower benefit procedure compared to the sling. And then, you know, our sling procedure is really our primary treatment for stress incontinence. You know, it can either be done using fascia with an abdominal incision. It is more frequently done as a minimally invasive procedure with a surgical quality mesh. This has been studied at the NIH level, 600 women at 2 years. Success rates are about 75% and high patient satisfaction of 87%. And pretty similar outcomes in another randomized controlled trial. Again, about 60% consider themselves dry, 25% improved, and about 15% didn't really get as much benefit. But 80% report their symptoms are much better or very much better. And at 2 years, the retreatment for stress incontinence, either surgery or an incontinence ring or pelvic floor muscle work, is about 3 to 5% in these trials. Looking at longer term outcomes in that same NIH study, when they followed up women at 5 years, the surgical retreatment, or just the SUI retreatment, had increased to about 9%, but about 83% of women still felt like they were much better or very much better. And same thing with that second trial that you can see. So pretty consistent, like 80 to 85% success rates, even when you get into the 5-year range. This is just showing SUI retreatment, like we talked about, in a claims database looking at Medicare beneficiaries, about 7.5%. In terms of people worrying about sling, like erosions, side effects, complications, it's really quite low. This was, you know, over 90,000 women followed for 9 years. And there was, you know, about a 3.5% rate of needing to revise the sling for erosion or because it was too tight. And again, that about 5% reoperation for incontinence. Denise, I'm going to spend a few minutes going in overactive bladder because we got started. Is that okay? And then I'll hand it over to you. Yeah. So I just wanted to spend a few minutes talking about overactive bladder. This is the primary symptom is urgency, often accompanied by frequency or leakage. And this is something where behavioral treatments can really be effective. So watching what you drink, like decreasing caffeine intake, when you drink it, avoiding fluids a few hours before bed. Again, pelvic floor muscle work is a really important component that we use for first-line therapy. Medications are also common, and then there's third-line therapy as well that I'll talk about. So pelvic floor muscle exercises, again, about 80% of women report improvement after pelvic floor muscle exercises and significantly decreased leakage episodes. Medications also reduce incontinence episodes. There's a pretty high discontinuation rate by about 6 months. This is not just relative to overactive bladder. This happens in a lot of chronic medical conditions, but I think it speaks to the side effect profiles and also managing expectations and also bringing in those behavioral treatments and pelvic floor muscle work, I think can enhance persistence, adherence, and overall improvement. So the most, you've heard about antimuscarinics for a long time, like oxybutynin, tolterodine, fesoterodine, what have you. There's very well-known side effects of dry mouth and constipation. There's also some emerging evidence of a risk of cognitive impairment in some patients over the long term. It's not really known in an individual what the risk factors are, but it's something to keep in mind. The beta agonists or the newer kids on the block, they really have fewer side effects. There's a risk of increased blood pressure in the trials, although on average, the risk of worsening blood pressure was quite low, and insurance coverage can be problematic for some. But because of this emerging evidence of the cognitive effects, I really try to get people on the beta agonist, at least as a trial to start. It's not better otherwise in terms of efficacy necessarily. I would encourage everybody to take a look at some of these data points. So in JAMA, this was kind of this first trial that came out a few years ago that showed an increased risk of about 1.2 to 1.6 of cognitive impairment in patients that were taking antimuscarinic drugs. This was patients 55 years and older. So overall, the risk is still very low. And we don't have individual risk factors, which is a little frustrating. And sometimes these medications are the ones we have to use, but we've started monitoring this in our practice. And also when you compare antimuscarinics to beta agonists, again, also an increased risk of 1.2 of dementia in the anticholinergic users versus the beta-3 agonist users like mirabegron or the newer one, vibegron. Interestingly, this risk wasn't seen in females as much. It really, when they separated out the genders, they only saw this risk in males, but something to keep our eye on in the emerging literature. Also, I just wanted to say a quick thing about mirbetriq. There's some sense since the beta agonists that there are these same receptors on blood vessels, that there's some risk of cardiac events. It's been shown that there's really doesn't seem to be any increased risk of heart arrhythmias, cardiovascular events like a stroke or MI. So it seems to be quite safe. But in my patients that already have hypertension that are on medications, I ask them to monitor it. And every now and then I do have someone that notes increased blood pressure that seems to persist. Hard to tell whether that's part of the natural course of disease or the medication, but we tend to stop the medication and then maybe just let things settle out for a little bit. Again, this is just showing the when you compare it to placebo, not that much difference, maybe a little bit. So I'm keeping my eye on this in the literature, but the only real contraindication is for people that have uncontrolled hypertension of like 180 over 100 or greater. So that's the only real contraindication, but people that have labile hypertension that are trying new medications, I tend to hold off until they're on a stable blood pressure dose. Botox is an office procedure where we inject kind of micro amounts of Botox in the wall. This is tolerated by the vast majority of people in the office. About 70% have at least 50% improvement. Remember, these are women that have refractory overactive bladder that have not gotten better with lifestyle, behavioral medications, what have you. It does have to be repeated every 6 to 9 months, just like when it's used for other conditions. We can also implant a pacemaker for the bladder. Again, about 50% of women see at least 50% improvement. The traditional battery lasts 3 to 5 years if it works, and then you have to change it out in a simple outpatient procedure. There's also now a rechargeable battery, which is smaller, and you can just charge it up once a week like you do with your other devices, and then it will last much longer. Just comparing Botox to sacral neuromodulation. In this trial at 6 months, it looked like Botox worked a little bit better to achieve complete resolution and greater than 75% reduction in incontinence episodes. But Sometimes the Botox works a little too well and people have trouble urinating, just like people can kind of get like the frozen foreheads. Their bladder might get almost like a flaccid paralysis. So there is about a 6 to 8% chance of needing to do self-catheterization. So it's low, but it can happen. So that's just something you have to keep in mind. So, just to wrap up, what can be done in a primary care office? Again, this is something that really requires primary care input and not just urology kind of view on it. But, in response to some of the previous barriers that primary care has reported, there is a very simple screening questionnaire called the 3IQ. It's pretty sensitive at detecting urgency incontinence and stress incontinence. So this can be used, this 3IQ, your patients that are in the waiting room, they can fill this out and this can help direct you to primary treatment. I think the biggest thing is just giving patients a diagnosis. They don't have to do something right then and there, but letting them know, hey, this is a thing. It's common. It doesn't have to be your life. It can get worse. Like just kind of having somebody listen to them goes a long way. They might circle back to you at some point. Education goes a long way. I know, believe me, I know that you guys don't have time to do all this education in your office, but there's a lot of great handouts. If anybody's interested, please let me know. They can at least be handed to patients. You could always initiate overactive bladder medication. I think follow-up is important if you're going to be treating somebody specifically for incontinence. Maybe use your advanced care providers, a video visit, a quick touch-in, in a month or two. And then referral is needed. You could refer right at the beginning if you want to, but I think a lot of this could be done, maybe initiated. So, just to wrap it up, there's good first-line therapies that are not surgical. There's effective medications. We're really blessed and lucky to have some really good Yale-based pelvic floor physical therapists. And then for people that don't respond, though, there's really simple office procedures and minimally invasive outpatient procedures that can really give patients back their quality of life. And I bet Denise hears this a lot too, that they wish they had done it sooner, because a lot of women suffer with this for a long time and it's really unnecessary. And I think we can do better as urologists from a public health messaging standpoint, and maybe, at the primary care level, also just let people get the foot in the door by just kind of mentioning it and mentioning that there's treatments available through the Yale system. So anyway, when a few minutes over, I'm going to toss it over to Denise now. Thank you so much for listening. I look forward to answering any questions at the end. And Denise, I just stopped my screen share.
Okay, perfect. So let me just share my screen. So hi, everyone. I'm Denise. I'm a physical therapist here at Yale New Haven. And specifically, I'm a pelvic floor PT. So thank you for having me. And I'm going to kind of talk more about the conservative approaches to patients with, especially women with urinary incontinence. So our hospital's mission and values. So again, as I mentioned, I'm going to define pelvic floor PT as opposed to kind of our primary PTs, orthopedics, et cetera. I also want to discuss some of the evidence-based practice. I think Leslie did a really good job of outlining it, but more so on the physical therapy side of things around urinary incontinence. And then also talk about some of the assessments and behavioral interventions that we use as PTs. So as physical therapists, typically we are movement experts. So one of the biggest things that we do is watch people move, whether they're walking, squatting, sitting, going from the floor, rolling in beds, et cetera. So those, we want to see how people move. We want to be able to kind of touch and feel how things are interacting. And then specifically as a pelvic floor PT, we, myself included, have a higher or more specialized training in the pelvis and specifically what's happening around the pelvis, whether we're looking above at the abdominals interacting with the pelvis and the diaphragm, or looking below at hips, ankles, knees, et cetera, and how we're going through that kinetic chain. And all of this really relates back to the things that can become dysfunctions in the pelvic floor, including urinary incontinence, certain bowel incontinences, pelvic pain, and sometimes sexual dysfunction. So some of the ways that we're screening and then predicting kind of general outcomes for patients are based on these factors. So thinking about their age, certainly we know like healing, things slow down at a certain point. So, and particularly when we're thinking about estrogen in the female pelvis, we have a change in collagen, we have a change in muscle density, and then just general like lubrication and things like that. So, comparing some of our pre versus postmenopausal patients. We also know that surgery makes a difference in this patient population. So sometimes we'll see maybe less fair outcomes with patients that are post-surgical, whether it's hysterectomies, C-sections, things like that, that will change and add scar tissue to the area and just kind of change the general, dynamic of the anatomy. We're thinking about comorbidities. So diabetes, we know has a risk of increased urination, CHF, and things where we're having increased fluid retention. We're also looking at gait speed. So how quickly one walks indicates a lot of different features of their life, but particularly how quickly they can move to the bathroom. And so when we're thinking about patients that have functional incontinence, especially those in our skilled nursing facilities, or just some of our general like older population that's living at home, getting to the bathroom sometimes can be one of the biggest challenges. And with that, and if there's a risk of fall, obviously that's something, especially with our patients with nocturia or voiding at night, that can be a kind of a danger. Longevity of symptoms, how long things have been going on for. Usually the longer that they've been going on for, the more challenging they are to treat, or the longer they're going to need for potential therapeutic interventions. Strength, I'm always looking at a strength as a physical therapist. So whether it's the pelvic floor muscles or the hips and abdominals and how all of those are interacting together. When we're thinking about the core, we're thinking about these three groups and how they're functioning. Weight, as Leslie actually mentioned before. So we know that your urge urinary incontinence, UUI, is associated with increased weight or BMI. And now we're even thinking about abdominal circumference, because especially postmenopausal women potentially have more adipose at the waistline. Cognitive decline. So certainly if patients are, cognitively impaired in some ways, it can make it more challenging for them to react and respond to their urinary urges. And then again, the ability to multitask. Some people just, get very focused on what they're doing and maybe are not, again, paying attention to those urges that they're feeling. So just some statistics. Obviously, we know that, urinary incontinence is very common, particularly in women over men. Approximately 13 million Americans have some form of incontinence, which is like 1 in 3. And stress urinary incontinence is typically the highest, with urge falling after that, and some form of MUI or mixed urinary incontinence. We see a spike in some of the younger ages, and then we definitely see it in some of our postmenopausal patients as well. So looking at the bladder and how it functions, again, because as a PT, all I'm thinking about is function, function, function. So the normal bladder function is, the kidneys filter and make urine, it moves through the urethras, and then we collect urine in the bladder. And then hopefully the bladder pressure maintains and before it comes out through the urethra. But whereas in stress urinary incontinence, there's an increased pressure at the top of the bladder or around the bladder, which occurs when these pelvic floor muscles don't respond to the task of pressure to the bladder, and it's greater than that of the sphincter. Whereas urge urinary incontinence is caused by typically a sudden bladder contraction, usually of the detrusor, and unfortunately, this usually cannot be consciously inhibited. So patients then have leakage as a result. The other types of incontinence that aren't shown here are mixed, as I mentioned, mixed urinary incontinence, which is a combination of both the urgency and the stress, overflow, or neurogenic bladder disorder. So some of the evidence around stress urinary incontinence that I use to treat my patients comes from a physio in Australia, Paul Hodges. And so one of the first articles actually that he presented was back in 2000, and he talked about the diaphragm and the pelvic floor and their connection. And so essentially what we think about is, the diaphragm being the top of a canister and the pelvic floor muscles being the bottom of the canister, and how the two are interacting with each other. So when the diaphragm and the pelvic floor work harmonious, or they're synchronized, they work well together. But if the diaphragm is overpowering the pelvic floor or vice versa, that's typically when we're leading more to these stress urinary incontinence symptoms. So if we can, as a PT, and I'm thinking about muscle, if I can get that diaphragm, which is our primary breathing muscle, to facilitate a better pelvic floor muscle contraction, typically we're going to see a decrease in our urinary incontinence. And then interestingly, one of the more recent articles by Mara de Santos showed that incontinent female athletes had greater pelvic floor strength than continent females, their female colleagues. And I found this to be very interesting because a lot of the earlier research in pelvic floor muscle training showed, 60 to 80 Kegels or more a day for continents. And what we're finding now is that it's actually much lower than that. So in this case, more is not necessarily better. It's really about how you facilitate and use the contraction versus how many that you're doing. So as I just kind of alluded to, some of the stress urinary incontinence interventions that I'm using in my clinic are around pressure management. So with the diaphragm, if we think about a balloon and we think about the diaphragm being on the top and the pelvic floor being on the bottom, if we're squeezing the top of the balloon where the diaphragm is, we are inversely increasing pressure in the pelvic floor. And so we are actually working against the bladder. So we really want to try to maintain that pressure management system. So making sure that we're breathing well. If we're having any paradoxial breathing, which is kind of this reciprocal motion, how can we start to change that and facilitate a better contraction for these patients? Alignment and body mechanics. So the way we move, sometimes we work against ourselves versus for ourselves. So thinking about if we sneeze, if we cough, if we're in a slightly flexed position, do we, instead of being straight over the bladder, do we reduce some of that pressure that's going vertically down? So, thinking about where we are, how we're doing things, and how it's affecting the bladder specifically. And then, as I mentioned before, abdominal and hip stabilization, because when we think about the core, it's really made up of the abdominals and the hips and the pelvic floor being kind of that centerpiece. And so we want to make sure that each of those pieces are working together. If the abdominals are stronger than the hips and the pelvic floor or vice versa, are we having some issues with pressure, and can we improve that system to work a little bit better together? And then of course the pelvic floor, we do want to make sure that it is moving and facilitated and activated to the point that we need for the pressure management. And so, we're thinking both about our type 1 and type 2 muscle fibers, whether, the slow twitch or the fast twitch, and making sure that they are contracting the way that we need them. And then I do test bilaterally. So when I do a pelvic floor assessment, I make sure to test kind of both sides. And again, make sure that one is not necessarily stronger than the other. Moving on to urge urinary incontinence. Again, there's some very interesting studies about behavioral therapy, which I'll get into a little bit later. But using some of that kind of change in behavior versus necessarily just working on strengthening and other things. And I also find that it can be a good combination with some of those pharmacotherapies or some of the other in-office procedures that Leslie mentioned before, Dr. Rickey mentioned before. And then of course, doing some hands-on release, because, again, as PTs, we like to put our hands on people. So working on scar tissue and making sure that it's mobilized correctly. So it's allowing things to move the way that it's supposed to. So again, some of these interventions, mobilization. So I am very big believer in seeing all this, especially the abdominal and the pelvic scars, and putting my hands on them, feeling them, seeing how they move, and making sure that things are kind of gliding and moving well together. So we and then myofascial release coming into the pelvic floor, making sure that, again, those muscles are working well together too. If there's areas of tension that people are holding, it can, tighten around the bladder, which can, again, be part of the cause of some of these symptoms. The interstim or e-stim that Dr. Rickey was mentioning, we can actually do as more of a outpatient internal probe. And I think sometimes it's a good trial for patients to see, how they do with it. And sometimes I've had patients who just need a few sessions of e-stim and actually do really well. It kind of resets or retrains the bladder. I do a lot of conversation and discussion with patients. So asking them what they're doing, how it's working for them, and then making small modifications or changes to how they're consuming fluids, what they're consuming. And sometimes it's also just giving patients norms, like understanding what is normal and what is not normal. Some people really have no idea, or they rely on their girlfriends and other family members to kind of get a sense of what's normal. So going through kind of, especially the first day, like, what are you doing and how's that working for you? And what are some of these small tweaks that we can make? And then some urgency techniques. So, thinking about the Pontine Nutrition Center and its effect on the bladder, and, trying to work on getting people to breathe and relax and calm down that central nervous response every time they're getting these urgency techniques or urges can be very helpful. And then I think it's really key and important to talk about bowels when we're talking about the bladder, because the system is really small and there's a lot of overflow between the two systems. So, oftentimes we'll see if we can reduce some constipation symptoms for patients through fibers and movement and things like that, we can actually have an effect also on bladder function, and particularly urgency. So my big things are talking about, discussing these symptoms, because I think, again, it's important to tell patients that although these symptoms are common, they're not normal, and they can be treated in various ways. Again, whether it's through PT or, relying on some of our other providers to start to make a difference on these symptoms. So teaching them that it is possible to affect them. And quality of life is just so important. Having to rely on a pad or some kind of incontinence device is, costly and sometimes frustrating. So if these patients, if we can start to take away some of these security blankets, oftentimes people get really comfortable with using a pad. It's something that, it's there just in case. And as we know as providers, sometimes being comfortable doesn't help us to kind of get away from where we currently are. So, sometimes it's just kind of starting to gently nudge patients out of their comfort zone a little bit, to get them to be a little bit more reliant on their muscles and some of these other techniques, as I discussed before. And hopefully that helps to increase some of their satisfaction with life. And, mentally, I think that makes a big difference too, is, if you're feeling really kind of down about your symptoms, sometimes that can actually provoke them or make them even a little bit worse. So treatment wise, one of the things that I think is very important, and what I try to outline on the first day, is making sure that, we set realistic patient goals. I ask them what their goal is for being here, and then we kind of outline some of the objectives to get towards their goals. And again, I think it's important to refer and rely on our team. So bringing different viewpoints and different treatment options to patients, so that they feel like they have multiple tools in their toolbox, and really just empowering patients, making sure that they feel like they are kind of in control, because, I think occasionally people can become reliant on their providers, and it's really important to get them to kind of work on self-management. And some references, and I think we were gonna kind of take some questions.
Thank you both. Those are both really excellent lectures. I actually have 2 questions because my practice is primarily focused on avoiding dysfunction, bowel and bladder incontinence. So for Dr. Rickey, how young do you consider doing sacral nerve stim?
That is a good question. I think I've actually taught, I don't think it's really, I think I've asked Adam Hittleman about this. I don't think that they use it in the pediatric urology group here very often. I don't have a great answer for that. I have implanted it in women in their 20s. To be honest, I'm not sure about its use in people younger than that. Like, is 19 different from 21? I don't know.
Well, that's always the question. Like,
Yeah.
at what point does it become? I've done this for 21 years, and Izzy Franco I've seen do literally 2 in that time. So, I mean, those are our most refractory patients, and so
the other thing is when you hear about these overactive bladder treatments, you got to remember there is overactive bladder and urgency incontinence episodes, and then there's urgency frequency that can be almost like a bladder pain IC type thing. So when you hear about success rates for Botox, for medications, for sacral neuromodulation, they are primarily referring to reduction in urgency incontinence episodes.
Right.
So you kind of, that we spend a little bit of time, that's why I kind of focused it more on the incontinence. Sometimes the traditional overactive bladder medications, in particular in 3rd-line treatments, don't work as well for the more sensory urgency frequency syndrome that's not really related to leakage.
right, that makes sense.
Yeah.
We and so to, I guess, Denise and Dr. Rickey, we do a lot in peds and in our adolescents with constipation management. So for our population, we see about half improve with good constipation management. And I always say, if I ask all my patients whether or not they're constipated, probably 90% of them say they're not, and 90% of them are. So we do spend a lot of time on that, and you briefly touched on that, Denise, but I was just wondering what the incidence is in improving these lower urinary tract symptoms when you do address constipation.
I will say one that I ask everybody about it, and a lot of times they're not there to see me for that, but I do if they're straining. So I will say the literature in adults isn't as robust as it is in kids about improved constipation, improve your voiding function, or your, that being said, I think there can be long-term detrimental effects to the pelvic floor from chronic straining, over time. And so I try to get all of my patients on some sort of bowel regimen if they're having any kind of straining or constipation. I personally start with fiber supplements and then tell them to add on stool softeners if they need more than that. Like if they say, oh, I have a bowel movement every 2 weeks, they're going to GI. Does just treating the constipation help their incontinence? I'm not sure those data exist very well, but I think there's global pelvic floor health benefits for prolapse and incontinence. But what do you think, Denise?
Yeah, I mean, I would agree. There's not a ton of research on it, but I just think common sense wise, it's a small area, and pressure, again, when I think about pressure management, I'm thinking about it both in the bowels and the bladder. And so I want to try to reduce as much pressure on the bladder as possible. And I agree. I think that's more shown and demonstrated in the pediatric population, especially with like spinal bifida patients and things like that. But I just think, like work smarter, not harder. If things are moving through the system, it just feels so much better. And to your point, people can be having a daily bowel movement but still be constipated. So I think it's important to kind of go through and kind of hash out the details with them a little bit so that they know kind of what the expectations are.
I think it's also kind of speaks to the need to assess all the different functional elements of the pelvic floor. So if they're going to take fiber, then they need to make sure they're drinking enough water, but they might not be drinking water because they have urge incontinence and they're going to leak. So, so sometimes you have to treat their incontinence first, but then you can't use oxybutynin because that's going to cause constipation. You know, so you have to think about all these things together. And sometimes you have to triage what you're going to do in terms of what you're going to treat first and try not to make something else worse.
Mm-hmm. Oh, absolutely. That's a very, very good point. And we do find also, as I'm sure, like you just mentioned, that people will try to solve I thought it was fascinating how you were talking about people just living with it. It's accepted. There are tons of commercials for pads. I've never thought about that before, but that's 100% true. And they try to self-medicate by just not drinking.
Well, what happens too is it's not, so the pads are okay, you know, it's just that symptoms are going to progress, like in some people. And so the pads don't prevent the symptoms from progressing. And it's not like a Band-Aid or they're like, I don't have a problem with it. It's just that if the symptoms are starting to progress, you got to do something about it. Like the pads are very passive. I think it's okay if you're doing that so that you continue participating in activities, as long as you're doing something active to address it as well.
Oh,
like whether you're doing the exercises or, you know, paying attention to it. Otherwise, eventually the disease is going to overwhelm your ability to manage it. And at that point, the symptoms can be quite severe and might not respond to conservative treatments anymore. So
right.
that's
and knowing there are options. You don't have to only do the pad. For you, Denise, what are the specific instructions you give to women for Kegel exercises?
So verbally, it's usually, I kind of like to make people laugh. So I think about, I teach people like, think about drinking a smoothie or a milkshake. So kind of pulling that fluid or liquid up the straw, because I think a lot of women think of the Kegel as just a squeeze. And it's really more of that levator activation that we're looking for, that deeper level. And so, you know, that puckering of like your mouth is really similar to the puckering of like the vagina or the anus. So visually that seems to work for people. And then I do a lot of hands-on and pelvic floor, you know, manual assessment as well. So depending on how comfortable people feel, and it might not even be in the first session. You know, as a PT, I'm lucky because I get to spend like multiple weeks usually with people and half an hour to half an hour sessions with people. So I really try to develop like a rapport and a connection with them. And so doing some of that hands-on, like coming into the pelvic floor and having them manually contract against my finger with that verbiage seems to help. And then the other big piece of that, as I mentioned with the diaphragm, is making sure that they're not holding their breath when they're doing the contractions. Because again, a lot of women, you know, like the squeeze, really try to hold their breath to kind of like pull up and in. And, you know, you're working against yourself if you're holding your diaphragm and then pulling up in your pelvic floor. So, you know, giving them the cue of exhaling with contraction to feel that kind of pull up and in as you exhale, so that you are utilizing both the best aspects of the pelvic floor and the diaphragm together.
I think also for people that do, you know, primary care providers that do woman care in their office and might be comfortable with pelvic exams, one thing that's common if you don't do a lot of these, a lot of women will Valsalva instead of squeeze. And when I have some new trainee, like learners with me, like residents or fellows, they're like, oh, it's 3 out of 3. And then I tested, I'm like, no, that's not a contraction. They're pushing, you know, and it's just a little, it can be quite impressive. So it can be a little hard to tell. And also to Denise's point, you'll still see people like their bodies levitate off the table. And so I'm nowhere near as smart as Denise in assessing all those things. But I tell the patients, I'm like, look, your shoulders shouldn't hunch, your stomach shouldn't tighten, your legs shouldn't flex, you know. And so I try to coach them that way. And you can get people to do it at least some, you know, better than they were doing it. So just like some few tips to look at when people are doing it, make sure they're contracting and not pushing, and make sure they're really just using, again, that pulling in motion. I use a marble, pretend you're pulling a marble into your vagina. And that they're not flexing their entire body like this and holding their breath. They sort of laugh when you say that. So.
Yeah.
It's definitely more complicated than you think, right? Once you've been doing it for a while, you realize it's way more complicated.
But I don't want to scare people too. I know like we're talking about sort of complex things, and the bottom line is some women like aren't going to be able to come into an office repeated times. And so sometimes if they're doing it correctly and you're not, kind of concerned that they're going to do it incorrectly or push instead of strain, getting them even started at home a little bit in the right patient can be empowering for them and can see a difference. But we do use a lot of our pelvic floor physical therapy colleagues, and the women really like it too. Like Denise said, they spend a lot of time with education. So they feel good even just about the education part of it.
Are there any apps or, I don't know, smart type? Anytime I try to talk technology, I always come off like a phony, but, apps or things that you recommend people put on their smartphones to help track or keep them, focus, reminders, that kind of stuff?
So not necessarily an app, but kind of an old school like bladder diary. So like people track their periods, sometimes tracking intake and outtake can be really educational for people and enlightening, because sometimes we're just not aware of how much or what we're drinking and how it's affecting. And so like these, like especially, I find with like my teachers and nurses stereotypically, they're limited on how often and when they can use the bathroom. And so they like drink these large volumes of fluid in like concentrated period of time, and then wondering why they're having to like run to the bathroom. So I think thinking about like spacing things out oftentimes can be very successful for people. So it's not necessarily like apps. And then there are the biofeedback devices. I'm sure you can kind of speak to that a little bit more, Dr. Rickey.
Yeah, we don't use any specific apps. There are trackers like Denise said. There's also some newer sort of this niche market where there's devices that can go in the vagina that can wirelessly connect to your cell phone and give you almost like biofeedback curves. And some people just do better with having that feedback or those reminders, or kind of having a schedule that they're sticking to. So particularly if unfortunately we don't have pelvic floor physical therapists in every corner of the state. We're pretty good coverage along the shoreline and in the mid-state, okay. And when you get up to some of the more northern parts of the state, you're just it's a little bit of a dry area, so to speak. So sometimes some of these other resources can be helpful for getting people some level of intervention. So, there was one other thing I wanted to say for some of the people that are on the call. When I talked about patient handouts, the American Urogyne Society and the International Urogyne Association, they make some really nice patient handouts. We actually, and the IUGA ones, the international ones actually come in different languages, but for overactive bladder, for stress incontinence, for pelvic floor muscle exercises, for pessaries, for non-surgical treatments, we've actually incorporated some of them into our after visit summary dot phrases, but you can also find them online. I'd be happy to, if anybody has any questions, they can email me. But again, sometimes just giving somebody a name, a diagnosis, some hope, that there are treatments for this. If it gets worse, it kind of just, like I said, gets their foot in the door a little bit, because a lot of people they just really normalize it and they think everybody has it because they're not talking to anybody about it. So they just assume everybody has it. And again, it can progress and progress and progress to the point where we can still see it and treat it. And sometimes we can make a dent, but sometimes it gets challenging.
Absolutely. Denise, I think this is for you. Thank you for mentioning the pelvic floor therapist. How many sessions do you recommend for someone with a pessary?
Oh, the pessary. Well, so I don't fit people for pessaries. Usually the APRNs do that. But with working with prolapse, it really depends on the patient. Again, how in tune they are and how quickly they learn things. So like with working with strengthening and behavioral modifications and things like that. On average, I would say just for my typical patient, urinary incontinence, prolapse, et cetera, I see people anywhere from 6 to 8 weeks. And that can be more or less, again, patient depending and also insurance depending at this point. Unfortunately, that dictates a lot of our practice as well.
That's definitely true. And for the, when you were talking about the mirror background, we have a lot of trouble with that, unfortunately, as well. So I think, all right, I think that's it for tonight. We're on the hour. I want to thank both of you again for coming. This was a really interesting talk and very useful. You will all receive links for viewing this at a later date. Feel free to send those links to friends. This is eligible for 1 CME credit. So thank you again. I hope everybody has a good night, and we'll see you all soon. Thank you.
Thanks, Therese.
Thank you.
Bye-bye.
Bye-bye.